So here we go. Our first case is case number 1, a 26-year-old female presented to the ER with left eye swelling. The symptoms initially improved with antibiotics, but then the edema recurred once the antibiotics were stopped. And she presented again a subsequent time with left eye swelling and intermittent clear rhinorrhea for the patient. She expressed she was concerned for CSF leak. On our exam, she was intact and had the periorbital edema, but did not have any evidence of CSF leak or rhinorrhea. Victor, I think I saw you in here. What do you see on these images?
So these are MRI images demonstrating it seems to be sort of like almost like a cystic lesion. So it's like hyper intense circumference with a high interior invasion into yeah, so low circumscribed lesion, I think with potentially orbital involvement and bony involvement as well.
Okay, thank you. And what kind of sequence do you think we're looking at here? Both of your heads all the same.
It's T1. I don't think there's a GAD, is there?
That is with gadolinium, yeah. You can see the little
yeah.
So how would you describe the enhancement?
It's not contrast enhancing or perhaps rim enhancing.
Rim enhancement, yeah. Okay, I agree with that. And it's above the orbit, right? And here's the frontal sinus. I don't know if you can see my pointer, but this is a frontal sinus, so it looks involved there as well, potentially. Hard to say exactly where it ends and begins on this, but yeah, it's compressing some of the extraocular space. So here's the next set of images. What do you see here?
Fusion restriction on DWI and hyperintense on T2. So this would lean more towards an infectious process. Oh, sorry, and dark on ADC. Perfect.
So this is your differential diagnosis slide. So go ahead and throw some out.
So abscess would be one. With the fusion restriction, I don't think that's typical of a cyst. I guess lower down could be a tumor, maybe a glioma, but not high on my list.
Okay. So let me go back. I said, like you mentioned, abscess, mucocele, could be an epidermoid, metastasis, also possible dermoid, but it's not at the midline. Giant cell reparative granuloma, and giant cell tumor at the bone, as well as aneurysm bone cyst. The bottom are less likely, but possible. And Dr. Goltekin, I'll hand it over to you.
On the left has what we call the flaky dry keratin, which can be the content of epidermoid or dermoid cyst. And on the right side, you see inflammatory changes on the top. And at the bottom, you see some giant cells too, with the keratin in the stroma causing this giant cell reaction. So it's like a ruptured cyst of this kind. Epidermoid versus dermoid depends on whether or not you find adnexal structures. When you find adnexal structures such as sweat glands, etc., in the lesion, then it's a dermoid cyst. If you just purely find squamous cell lining for the cyst, then it's an epidermoid cyst. Okay. So it was difficult to tell for us which one this is because we didn't really see the epithelial lining very nicely here, which can be, the case in surgical cases. So epidermoid or dermoid cyst.
Thank you. So I just wanted to review for the residents the characteristics of dermoid and epidermoid, as Dr. Goltekin started to allude to the pathologic or histopathologic changes that they see. But dermoids are typically at the midline. They have hyperintensity on T1. They don't have diffusion restriction, though they are bright on DWI. But when you look at ADC, they do not restrict, meaning the signal does not drop out and it's T2 shine through. So it's not actual restriction at all. There's also, as he said, adnexal structures or cutaneous elements, including hair, sebaceous glands, and sweat glands, as well as the other findings that are in an epidermoid, such as the keratin and the epithelium. And epidermoids are more commonly lateral, but can occur at the midline. They usually will follow CSF signal on T1 and T2, and really the signal that tells you that this is not an arachnoid cyst is diffusion restriction, because it will restrict. And then also there are no like adnexal structures or cutaneous elements below keratin. Both of them are benign. They both originate from inclusion of ectodermal components during neural tube closure. So you can think of them almost as a spectrum of how much ectoderm or how much of the 3 layers of development get enclosed in this cleft, because epidermoid would be the least amount of tissues. It would just be the epithelium basically. Dermoid would have some components of the lower skin layers, which is why there's hair, sweat glands, sebaceous glands. And then like on the far end of the spectrum is a teratoma, which can have all 3 layers of ectoderm, mesoderm, and endoderm. Then of course, like I said, they both contain keratinaceous material and desquamated epithelium and cholesterol crystals. And then this patient, since we did have diffusion restriction and knowing what we know about MRI findings, in addition to the histopathology, we made the diagnosis of epidermoid. She had a superimposed sinus infection with Moxarella, and that was why she got better with antibiotics, and then it recurred. She probably had an obstruction of her sinus partially with a superimposed infection that couldn't be fully drained and was not fully treated with antibiotics the first time around. Epidermoids that are ruptured, which Dr. Goltekin saw evidence of on that histopath slides, and also epidermoids that are infected are much more likely to present with acute symptoms and require surgical treatment, because otherwise epidermoid symptoms are usually very insidious and slow to be problematic to the patient.
So Catherine, I saw chronic inflammation and giant cell changes. This is different. This would be more polymorphonuclear leukocytes, neutrophils, if there was really infection, like an abscess in it. That's a different story. That would require me to call you guys personally, just to make sure that, people understand that there is an acute infection. And so this is not the case in this inflammation. This is chronic inflammation with giant cell formation, with nearby keratin debris. So this is just rupture, a reaction of the stroma to the rupture of the epidermoid cyst. Thank you.
Thank you, that's helpful. Yeah, so I guess I should clarify rupture, but she eventually was treated with 6 weeks of antibiotics because of the positive cultures at the time. Maybe that was not as clinically relevant in hindsight, but she did well overall and interesting. Thank you, Dr. Goldstein. So our next case is number 2. We have a 69-year-old male with diagnosis of non-functioning pituitary macroadenoma, status post endonasal endoscopic transsphenoidal resection in Michigan. And apparently the surgery was partially completed and then aborted for carotid proximity, is what the patient tells us. He was followed in clinic, and serial imaging showed growth of residual tumor that was present on prior studies and was not changing. His neurologic exam was intact. So let's see what I have on here. Sumed, do you want to try this one?
Yeah, sure. Can you guys hear me?
Yeah.
So this looks like, coronal MRI showing contrast enhancement of the sella region. It looks like there's a component of enhancement as well in between the right carotid loops, a little bit on the left as well. Yeah, I think, in line with what a pituitary macroadenoma would look like. On that sequence as well, similarly. Yeah, we have the similar, contrast enhancement of in the sagittal plane as well. Yeah, I would say differential for this one would most likely be macroadenoma for me. As
What else do you think it could be?
Yeah, I guess other tumors in this area less likely. Some of the things are like very homogeneously contrast enhancing, less likely being like meningioma. It doesn't have any it didn't look like it had any CIS finding suggestive like a cleft cyst, but I'll put it on there for cellular mass, though very low on the differential. Craniopharyngiomas don't really look like this, but I would say it's highest differential macroadenoma.
That's fair. Okay, good job. Thank you. Yeah, it's hard to imagine, especially when you know the prior path, to create other diagnoses. This is more for practice, just working on getting there's 14 different possible categories of diagnosis in the suprasellar region. So like you said, pituitary macroadenoma, meningioma, could be metastasis. All of these seem less likely, but it could be lymphoma, germ cell tumors, an aneurysm with abnormal flow, granulomatous disease like sarcoid, hypophysitis, even mucocele and lymphocytic hypophysitis. And then cell rest tumors like you alluded to, craniopharyngioma, could be epidermoid or chordoma, very unlikely, but finally the option of TB and pituitary abscess are there. So let's see this neuropath. Dr. Goldstein.
Yes.
Thank you.
So this is interesting because you're saying that this 69-year-old person is coming with a history of macroadenoma. Was it resected before?
Partially.
Partially resected. So I'm not sure if we saw that case in consultation. I think this emphasizes the importance of, looking at the patient's previous biopsy before they enter surgery in our institution when possible. Sometimes it's difficult. These 4 pictures here show you a very dense cellular infiltrate. Especially on the left top and left bottom, you can see islands of normal pituitary kind of smothered within this cellular infiltrate. And when you look at the infiltrate itself, especially with immunostains, you see that it's actually not pituitary tissue. It is lymphoid tissue. It's difficult to discern on low power H&E and on frozen sections especially, but and of course we go back and ask if this patient had a history of CLL. In this case, did he?
Not that we know of.
Oh wow!
Yeah.
So I sent this to HemPath. I said this is not going to be neuropath material anymore, and they did the appropriate stains: CD20 wall-to-wall positive, CD5 positive, CD10 negative, VCL2 positive, LEF1 positive. They diagnosed CLL or SLL in this case. It's rather a surprising case, actually. It's one of those entities that you just showed in the differential diagnosis of enhancing suprasellular mass. So that one of the take-home messages is, of course, not to assume that every enhancing suprasellular mass is a pituitary adenoma. Germ cell tumors are particularly difficult sometimes to diagnose in the cella. That's the second common area that germ cell tumors occur. And these are some of the, challenges in surgical neuropathology that we have to keep in mind. Okay, so go ahead.
Certainly, thank you for explaining all that. I thought it was a unique case too, and what I looked up, so I wanted to share with the residents. Lymphomas of the CNS, and particularly in the pituitary, are a little bit confusing, I think, as in a junior resident period until you have time to really learn about it. And I just want to distinguish, there's a couple ways you can get lymphoma in the CNS. So there's one way you can have a primary pituitary lymphoma, which means you don't have systemic disease, you don't have other CNS involvement, and you just have the pituitary gland with lymphoma. This is very rare. You can also have secondary pituitary lymphoma, meaning the gland is involved as part of systemic disease. So when we say primary pituitary lymphoma, that's the one I described, where it's just in the pituitary gland, not anywhere else, including in the CNS. And it, as I put here, it's 0.1 to 0.3% of pituitary tumors. And then you have primary CNS lymphoma. Usually it doesn't originate as the first finding on imaging in the pituitary. It can spread to the pituitary secondarily. It has been reported, maybe less than 10 cases is what I found in my search. So it's very uncommon. Like I said here, it's the cell types can be similar, primary CNS lymphoma and pituitary lymphomas. The most common type of lymphoma is non-Hodgkin B-cell lymphoma, but it can be any, mantle cell has been reported and a variety of other kinds. And then just to discuss again, secondary lymphoma spreading to the pituitary gland is already very rare. It's 0.5% of all metastatic pituitary tumors. And of pituitary tumors, metastatic tumors only actually make up 1% of all of the pituitary tumors. So you're looking at 0.5 of 1%. And that's for secondary lymphoma, which is more common. It's almost always, like I said, non-Hodgkin B-cell. You can also have diffuse large B-cell lymphoma as the most common subtype, but CLL and SLL is extremely rare as a metastasis, and I found 2 case reports of that. So a reminder to keep in mind.
Plasma cell neoplasms in the cella, like multiple myeloma, etc.
Mm-hmm. Okay, case 3. Eva, how about you help us with this one? The 29-year-old female who presented at 8 months pregnant with a first-time generalized tonic-clonic seizure. A couple other important history components is that she took a trip to Mexico 1 month before the seizure onset, and she was not compliant with her medication and continued to have seizures. On exam, she was intact. And here's the MRI. I'm actually going to play it for you, maybe if I can, because there's a lot of little lesions.
Yeah, so it looks like on the right, like small, like sub-centimeter contrast enhancing lesions, mostly in the left temporal lobe.
Yeah, good. Yeah, this is just for comparison to see that they are enhancing.
Mm-hmm.
Here's the next set of images. I'll play them again because there's so many little spots, but you can see very well there.
Mm-hmm.
What do you see?
Looks like there's just like a very small amount of like surrounding vasogenic edema. I mean, given she went to like Mexico, or did she have any other symptoms like diarrhea, nothing like that?
She denied other symptoms, yeah.
Yeah, I mean, I guess because she went to Mexico, I mean, maybe one of the differentials could be like neurocystic sarcosis.
Yeah, that's perfect. That's definitely kind of the first thought that comes to a lot of our minds on this one. Just because it's neuropath, I came up with other possibilities here, which could be like a herpes. This is atypical for herpes, but it could be herpes encephalitis. And usually the enhancement is gyral, not like focal circumscribed round lesions. And also for the neurocystic sarcosis, it's not perfect because usually that would be hyper intense to CSF on T1, and the cyst wall enhances, and we don't see that exactly here. So even the radiologist looking at these images said, you know, these are non-specific changes. It could be like a myelinating disorder, multiple sclerosis, vasculitis, or acute disseminated encephalomyelitis, and then of course tumor, metastasis, and glioma. So Dr. Goldtekin.
Neurocystic sarcosis should be considered, but you need to understand the timeline of her trip to Mexico. If it was 2 days ago, it's not going to work because neurocystic sarcosis would take time to develop, right? So, you know, if I tell you I have a seizure and have you been to a foreign country? Yes, like 3 days ago, I did a brief business trip to Mexico. That doesn't mean that I'm going to have neurocystic sarcosis the next day. I don't know the timeline of this here, but obviously this was not neurocystic sarcosis. So it's a very interesting little lesion. I think Dr. Stark was not even sure what the nature of this, you know, lesion was when he was operating, understandably so. And when I said this looks like a glioma on frozen, he wasn't surprised because I guess intraoperatively it made more sense to him. So there's this plaque-like lesion on the left, a big area of hypercellularity. And when you look at the right couple of pictures, it looks like there are spindle cells, particularly with a perivascular location, like almost like an angiocentric location. Yeah, those. This is not an ependymoma. And I kind of scratch my head. You know, this young woman, 29-year-old, temporal lobe lesion, appears infiltrative microscopically. Can we show the next slide?
Mm-hmm.
It's a glioma. It doesn't look like a pilocytic astrocytoma morphologically. It's gliofibrillary acidic protein positive. Ki67 is low on the right side. Very interestingly, ATRX expression is apparently lost. That means that this is probably a diffuse astrocytoma molecularly. And if this finding is correct and can be hopefully corroborated by next generation sequencing or any other mutation screening method, then this is, you know, an unusual looking diffuse infiltrative astrocytoma, adult type. IDH1 was negative. Again, in this younger person, typically if it's going to be a diffuse glioma, this should be an IDH positive glioma. If it's not, then we have a real problem here because these may act like glioblastoma. So I suggested that we do NGS studies in this case. I'm not sure if you have them.
I do. I'll talk about them. We do have them.
Okay, great, fantastic. All right.
Yeah.
So low grade astrocytoma, IDH. Yeah.
Yeah, awesome. So like he's alluding to, this is a little bit atypical in terms of how it's grading. There's areas where the Ki67 index is up to 15%, other areas where it's 2%, and usually we say less than 10% to be considered low grade, though that's obviously not at all a defining clinical marker, it's just an unusual feature. And then this did enhance. So just for the junior residents to review how enhancement is usually seen in gliomas. Grade 1, there's the pilocytic astrocytoma, DNET, ganglioglioma, all enhanced. Grade 2, which we typically describe as low-grade gliomas, and there can be lots of different types, do not typically enhance. And then grade 3, pleomorphic xanthoastrocytomas, PXAs, typically have a solid enhancing nodule. And then of course, grade 4, we know classic GBM does enhance, but you can have molecular GBM, like he said, if it has the wild type IDH, and it might not be at the stage where you're seeing enhancement, but molecularly it's going to behave like a GBM. So I just want to review quickly there's new WHO classifications for glial tumors, which I feel like it's happening all the time. It's hard to keep up. So they've recategorized them. Basically, there's adult type diffuse gliomas. These are the wild type ones usually. There's pediatric type diffuse low-grade gliomas, pediatric type diffuse high-grade gliomas, then circumscribed astrocytic gliomas. And they're usually more solid in terms of their growth. Then there's glioneuronal tumors and neuronal tumors like central neurocytoma, etc., and then epinomomas. So if we just look at these top 3 categories here for this patient, adult type diffuse gliomas would include an astrocytoma with IDH mutant, which she's not. Oligodendrogliomas, IDH mutant with 1p19q codeletion. She did not have 1p19q codeletion, so it's not that. And glioblastoma with IDH wild type. Then of course, pediatric ones, there's a new diagnosis, which was not present in prior WHO guidelines, called diffuse astrocytoma with MYB or MYBL1 altered gene. This is basically a finding of adult type tumors, or pediatric type tumors that can be diffuse but behave more benign. And then angiocentric glioma, which is also a new diagnostic category, polymorphous low-grade neuroepithelial tumor of the young, I didn't even go into here. And then diffuse glioma with the MAPK pathway altered. This is like the grade 2s that we're used to seeing on imaging classically. And then finally, the pediatric type diffuse high-grade gliomas. So these include the midline gliomas, diffuse hemispheric glioma. Then there's a pediatric high-grade with H3 wild type and IDH wild type. And then an infant type, which we don't need to go into. I can share these slides. It's just for the residents really to review. But for this patient, the final pathological differential diagnosis based on the cells included pilocytic astrocytoma, high-grade astrocytoma with pyloid features, diffuse astrocytoma with the MYB or MYBL1 alteration, and then a PXA. So as we've kind of alluded to, that things are unusual about this tumor. And I think that's why it's helpful to understand like the spectrum that these kind of tumors can be seen on. For another quick review of the actual molecular alterations and the grading possibilities of these tumors that I just described in our differential based on the histopath. This includes pilocytic astrocytoma, diffuse astrocytoma with the MYB alteration, PXA, and then high-grade astrocytoma with pyloid features and astrocytoma with IDH mutant. This patient had loss of the ATRX gene, and these two at the bottom, high-grade and astrocytoma with IDH mutant, both show the ATRX loss. And ATRX is a gene involved with chromatin remodeling that's been helpful recently in confirming diagnoses. So I'm going to explain a little more as to why that is. So the ATRX gene is involved in this check of the cell cycle here at the G2 phase. And then basically, if you knock that out, you only have this second check cycle to rely on to inhibit cell growth if there are abnormal genetic elements. So it's lost frequently in high gliomas, and that can lead to like dysregulation in the checkpoint cycle, basically. This was published in 2022. So cutting edge molecular stuff here. Then finally, the actual molecular diagnosis was low-grade astrocytoma with IDH1 wild type and loss of ATRX. So this is these are screenshots actually of her results that when Dr. Goldtekin sent them out, this is what we get back, which is way more advanced than it used to be. You can see here the IDH1 is picked. You can actually see all of the genes they test for. They list them all out. And they're all have some clinical relevance or correlate with evidence to back looking at that gene. So there's a lot of things that we still don't fully understand, obviously, but her H3, which is the histone mutation, was not detected. The ATRX was not detected, meaning it's lost. It's MGMT unmethylated. So all important things here. This is just over on the side, the genomic signatures. It's looking at the microsatellite instability, which this tumor is relatively stable. Also, like the tumor burden in terms of how much DNA to abnormal tumor DNA is present in the cells, and then the loss of heterozygosity. And then from our neuropath stains, they did these histone stains, which were retained or were non-mutant. And also the BRAF mutation was not detected. So all that.
And the CDKN2A-B are not detected either, which is good sign, because CDKN2B would give it to, you know, raise the grade to a grade 3 or 4. So, and the ATRX is not lost in this report.
And this result, yeah.
Yeah. So what do you think this is?
Well, so that's my question. I actually found this really nice diagram from this. So it fits this part, right? This is from Nature in 2020. The IDH wild type, yes. Nuclear ATRX not lost on those molecular studies, but lost on stains. So I kind of put it with lost because there's something abnormal. But then she does not have this histone mutation, and she does not have MGMT promoter methylation. So she doesn't actually, if you look at this flow chart, she doesn't fit anything, meaning we don't understand yet.
Yeah, so you have to start at the very top, which is histology. We do say that we see a diffuse astrocytic glioma. That's where the problem starts, because once it's a diffuse astrocytic glioma, then it would have to fall into one of these categories. And yeah, I don't know if everything was looked at. If you go back to your differential diagnostic slide, please, the one that you had a nice different, yeah, diffuse astrocytic, did they look at MYB, MYLB?
I did not see that. I didn't see them look at MYLB.
Yeah, you would have to look at what they looked at, the list of genes that they really test. So anyway, it's a little complex. I'm gonna have to take it up with the neuro-oncologist when they call me on this. But it doesn't really look like that the tumor is reading the book, so to speak, in this case. But it doesn't have any high-grade elements. The mistake that we don't want to make is assume that this is a diffuse astrocytoma and it's IDH wild type, and then of course that means it's going to act like a glioblastoma. So that's why I'm going always back to the first step, saying, could this be one of those specific entities like pyloid glioma, pilocytic astrocytoma, angiocentric glioma, things like that. So that's where I am. It looks lower grade, but a higher Ki-67 index in a younger person. It's going to be difficult. I'm going to have to look at this report myself. Okay. But thank you for the analysis. That was great.
No problem. I just, for me to learn in the residence, it's getting more and more complex each year, I feel like. So we'll try to keep up. This is our next case. Damien, are you there? Try to involve you on this. Awesome. So we have a 34-year-old Haitian male who presented to Jackson North with 3 months of neck pain, upper extremity pain, and then 2 weeks of progressive quadriplegia. Like he couldn't move at all anymore. His family was doing everything for him in terms of activities of daily living. He also had dysarthria and dysphagia at the time of presentation. He was initially worked up for Guillain-Barré syndrome by the neurologist at North, and then an MRI of the cervical spine was obtained. And I'll go into that. His exam is awake, alert. His cranial nerves are intact, but his facial muscular movement is extremely decreased with hypotonia. And then in the arms and legs, he's 0 out of 5 throughout. He does have intact sensation with no sensory level. He's areflexic. He has no abnormal reflexes such as Hoffman, Clonus, or Babinski. So here's our first image. What do you see, Damien?
Okay. So T2 of the cervical spine showing severe compression of the spinal cord at from 2 to 4, with a ventral lesion anterior to the vertebral body, sort of in a prevertebral fashion, with probably associated with swallowing difficulties. It also looks like there may be sort of some component within the canal itself causing the stenosis, and the vertebral body at C also looks compressed. It's fractured or not.
Good.
Is there a T1?
I'm just going to play the T2 for you gradually so you can see how extensive this is for your differential.
Extensive lesion. It looks like it's rising from the vertebral bodies themselves, but sort of hard to tell. Is there a contrast?
Yeah, here we go. So this is, both are contrasted.
Yeah, I mean, that sort of looks more like a peripherally enhancing collection there. It could be with some enhancement of the dura ventrally, so more concerning for a severe discitis, osteomyelitis that's now progressing to full-blown abscess with the epidural component, versus but looks more like an abscess to me.
Okay, good. Let me show you the CT just for completeness sake. What do you see here?
Like erosion of the C3 inferior end plate eating into the body. More consistent with an infection. It's been ongoing.
Yeah. It's likely a pathologic compression fracture. We just don't know the pathology, right? So, sorry, we'll go through a differential. You mentioned abscess. What else do you think it could be?
Well, yeah, I mean, so it's going to be infection versus tumor. So given it looks like it's eating away the bone, I mean, it could be some of the primary bone tumors versus a metastasis. Would probably be that on my differential.
Okay, good. So for primary bone tumors, it can be a giant cell tumor, which is what the radiologists were favoring actually based after these MRIs. Osteoblastoma, osteogenic sarcoma, chordoma, less likely But then you could have bone metastasis, lymphoma, plasmacytoma, though I think it's too involved to call it that here. And then multiple myeloma, local spread of malignancy from like a head and neck cancer or infection, of course. So good job. Thank you, Damien. Here's our pathology. Dr. Goltekin.
Okay, sorry, I kept talking without realizing I was muted. So on the left side, you do see at the top a heterogeneous infiltrate with higher and lower cellular areas. On the right side, at the top, you see a discrete dark pink, group of cells. These are histiocytes forming the granuloma. And in the middle, you can see that this discrete area is wall-to-wall positive with CD68, which is a macrophage marker. At the bottom middle, you see a giant cell. On the left bottom, yes, on the left bottom, you see necrosis. So, variably necrotizing granuloma with giant cells and acid-fast stain is negative. That means this is not tuberculosis. And it could be anything else that causes granulomas, including sarcoidosis and others. That's all I have.
So even though that AFB stain was negative, the actual intraop cultures from the tissue resulted positive for growth of Mycobacterium tuberculosis. He had it's unusual. How often do you see that where the AFB is negative and then the culture actually shows TB?
Actually, not infrequently. It also depends on how carefully the pathologist looks at AFB and how the preparation is histologically, but it's not very easy to find positive cells in the AFB. We did look at this carefully, of course, but it's not uncommon for the AFB to be negative. POTS disease is very uncommon for developed countries,
right?
But you do see this in other geographic areas.
Thank you, that's helpful. Yeah, so the AFB was negative here, but his cultures actually grew tuberculosis, which is also unusual because it's really hard to grow TB on culture. You have to take like 6 weeks to do it, but his grew like immediately. He had positive quantiferin gold. He also had Enterococcus in the intraoperative cultures. Of note, I'm not sure if this is all related, but he probably has some sort of immune compromised state that we don't fully understand because he had an infection with brucella, which is like a recurrent zoonotic fever with high IgM. And then he also, during his hospitalization, had Klebsiella and Actinobacter pneumonias. So poor guy did not have a great immune system here. But anyway, he's from Haiti. So we're assuming that, he had this TB infection for a long time and it involved the bone. Next case, Vignesh, are you still on? I'm gonna have you help out on this one. It's a 76-year-old male with 3 months of progressive numbness in the lower extremities. He says that when he's upstanding, all of a sudden his legs will give out without warning and collapse. He's had multiple falls because of this. He has numbness from the knee to the mid-calf, circumferential and bilateral. He has chronic urinary incontinence for like over a decade from urologic malignancies and urologic surgeries. His past medical history includes renal cell carcinoma, prostate cancer, thyroid cancer, bladder urothelial cancer, and he also has hepatitis C. Per his notes and U-chart with his urology and oncology doctors, his cancers are considered to be controlled or in remission since 2018. On exam, he has left IP and quad weakness 4 out of 5, bilaterally diminished sensation in the distal thigh to the mid-calf. He does have 3+ reflexes in the patella and Achilles and 2+ in the upper extremities, and clonus bilaterally with an equivocal Babinski. So his imaging results, I'm sorry, Vignesh, are limited. They were done outside and we did not have all the sequences, but this is what we have. And I'll tell you, this one is, the first one on the left is contrast enhanced. So what do you see here?
Sorry, my service in the VA is a little spotty, but just based on what it sounds like, based on his presentation, the imaging, it looks like he has a contrast enhancing lesion about the level of the conus, would be intradural extramedullary along the phylum. So I think my top 2 differentials would be either a mixed papillary ependymoma or a schwannoma.
Fantastic. So differential, yep, just like you said, mixed papillary metastasis possible given its numerous cancers, schwannoma, neurofibroma, meningioma, and then dermoid or epidermoid. So I wouldn't typically even include what this ended up being in my differential because it's so uncommon, but as we'll see, it can be a hemangioblastoma that's extramedullary. Dr. Goldtekin.
Yeah, so there's no doubt that this is histologically a hemangioblastoma. There is a richly vascular lesion with clear cells on the left, and those cells specifically stained with inhibin, confirming the diagnosis of hemangioblastoma. Easy case histologically, but slightly atypical in terms of location.
Thank you. And with his history of renal cell, I know like on frozen slides, it can look similar, but the inhibin confirms that it's not that, right?
Correct. And also, yeah, sometimes it's difficult to tell a clear cell renal cell carcinoma metastasis from hemangioblastoma, especially on the basis of histology alone. But this case really looked on the real low-grade side, the cellularity, the nuclear atypia, lack of mitosis, lack of necrosis. It really doesn't look like a metastatic lesion, which would be a little more atypical. Sometimes it's a hard question to answer. Not in this case.
Perfect. Thank you. Yeah, poor guy's now got 5 kinds of tumors. So his diagnosis was intradural extramedullary WHO grade 1 hemangioblastoma near the conus medullaris. Intraoperatively, it was clearly extramedullary and was like within the nerve roots and appeared more like a schwannoma. But of course, then frozen was sent and they said hemangioblastoma, which, it was a very bloody tumor. His genetic testing was negative for VHL. So hemangioblastoma tumors that are in the dura but extramedullary are more common in the cervical and than in the thoracic area. It's extremely rare at the location of the conus, and usually those patients do have VHL, which is von Hippel-Lindau disease or syndrome. But here he does not have VHL, and so this makes it even more rare. There's less than 20 case reports that I found with an extramedullary presentation, but it has been seen. We've seen it here before this case, and something to keep in mind. You can always, if you do suspect that, consider preoperative embolization, because these can be extremely bloody tumors, and it's something you might regret not thinking about preoperatively. But you can, of course, get that for all conus lesions that look similar because it's probably a schwannoma. So that's all I have for neuropath. Thank you, everybody.
Excellent. Well, as you probably noticed, this morning is a family affair. So Kat did the first hour of neuropath, and then now I'm giving my grand rounds presentation in the second hour. So I kind of wanted to talk about a lot of the trials in neurosurgery, specifically in cerebrovascular neurosurgery, because I think in morning conference, we used to, talk about these a lot, but frequently, now, especially with COVID, I think a lot of this has kind of gotten lost, and I kind of wanted to use this as a reference for the residents so that, I'm happy to share my PowerPoint with them afterwards, just so that they have an idea of kind of, in general, what these trials are and what they mean for us, especially those residents interested in cerebrovascular neurosurgery. So this is kind of just an overview of, of what the talk is going to be about today. As many of you know, I mean, we could spend probably an entire hour discussing these each one of these trials. So really today, the plan is not to go into too much depth in any of the one studies, but really to kind of provide an overview of each of the studies. So broadly, I kind of divided the trials into two categories. One is ischemic, and the other is hemorrhagic. I'm going to try my best to really discuss them in chronological order to provide some really historical context for each of the trials. And then also, I'm going to kind of interject some of my own research that we've done here, just because one of my clinical interests has always been leveraging big data to really see how these clinical trials have affected practice patterns in the US. So we're going to start with looking at the trials for ECIC bypass for steno-occlusive disease. So, I think these trials could potentially be listed in the categories of carotid stenosis or intracranial atherosclerotic disease, but I think they're kind of worth listing separately just because of the surgical technique. So I found it interesting, Dr. Fisher back in the day had already made this quote that he felt like it was conceivable that some vascular surgeon could find a way to bypass the occluded portions of the arteries during the period of ominous fleeting symptoms, that he thought, even as a neurologist, that anastomosis of the external carotid to the internal could potentially be performed. So historical context, in 1951, Dr. Correa, who was an Argentinian neurosurgeon, he was the first to perform an actual resection of a carotid plaque within a segment of the, within a disease segment of the internal carotid, and then performed an end-to-end anastomosis with actually the external stump. And I'll show you kind of what that means. And then Dr. Icesat in 1954 would be the first to describe the anastomosis technique in the literature. Warringen and Kuhnlin, who I believe were French neurosurgeons, performed the first ECIC bypasses from the common carotid using a saphenous vein. Although in true neurosurgical fashion, the patient ultimately did not survive, but they found that the graft was patent on autopsy. And in 1967, Dr. Yassergil would be the first to perform the ECIC bypass in a patient with an occluded ICA, and he did it successfully. So this is just kind of an initial, historical background into what these initial procedures looked like. So here, on the left, you can see Dr. Correa basically disconnected the internal carotid artery distal to the stump or distal to the plaque, and then anastomosed it to the stump at the ECA. And then Icesat was the one who actually resected the entire segment of the internal carotid artery involving the plaque, and then performed an end-to-end anastomosis of the ICA and the common. And then here on the bottom right is just an example of, what our kind of, typical carotid endarterectomy looks like today. So the first, bypass trial for carotid stenosis, intracranial stenosis, was done in 1985. There were close to 1,400 patients enrolled, which is a pretty large number, for trials like this. The inclusion criteria was that they had to have an ipsilateral symptomatic carotid stenosis, or MCA stenosis, or an occlusion. So I think in general, this trial, their inclusion criteria were relatively broad. These patients were randomized to either best medical management alone or best medical management plus ECIC bypass. So, interestingly, is what they found is that, at 55 months, which was the follow-up period, the average follow-up period, 96% of the bypasses were patent, But if they looked at clinical outcomes, there was really no benefit to the surgery, and that they had increased risk of stroke. And in fact, those patients with severe MCA stenosis or continued symptomatic complete ICA occlusion actually had even worse outcomes. So despite having good patency, they really found that there was no benefit to surgery at all. So then that kind of moves us towards the cost study, which is one I think that we more frequently discuss in our morning conferences with Dr. Hiros. The results that here were published in 2013. You can see that there was, the aim of this study was to really narrow the inclusion criteria, because the previous trial was much more broad. What they found here was that they really wanted to only look at patients with what they defined as a hungry brain. So they only had, about 200 patients enrolled, and they had to have ipsilateral symptomatic ICA occlusion with elevated O2 extraction fraction on PET. So that's how they diagnosed what we call a hungry brain, is that they saw that these patients, the ipsilateral hemisphere of the occluded ICA had increased oxygen extraction, meaning that they were really trying to get as much O2 out of the blood that was getting there. And so they randomized them again to best medical management versus the ECIC bypass. And in the follow-up period, again, at 2 years, they found that, again, bypass patency was, close to 100%, but they really found no benefit to the surgery. So these patients, they found really probably what happened is that there was a lot lower expected 2-year stroke rate at about 22% in the medical arm. And the surgical arm, again, had pretty high 30-day stroke risk at about 15%. So the peri-procedural risk of the ECIC bypass for these patients still kind of outweighed the long-term results. So, that kind of moves us over to the trials involving carotid stenosis. As I'm sure many of you know, there's a lot of carotid stenosis trials. So we're going to kind of go through each one of them, or some of the important ones that I think, should be discussed. This is again kind of, back to our timeline to kind of give you some historical context. Dr. DeBakey, who was a cardiovascular surgeon, is really credited with performing the first endarterectomy in 1953. Dr. Cooley, who was a protege of Dr. DeBakey, was then the first to describe the use of an intra-arterial shunt for those patients who didn't tolerate clamping during the carotid endarterectomy, and he used actually needles. And then Dr. McCall, who was a German surgeon, refined Dr. Cooley's techniques and kind of started using the plastic tubing shunting that we now see today. I think the most important thing here is that Dr. Winslow in 1988 was really the first to report the loose indications for endarterectomy. So I think in 1953, following Dr. DeBakey's development of the procedure, I think many people just started doing endarterectomies on anyone with carotid stenosis. So Dr. Winslow looked at a large Medicare database, so he's kind of a man after my own heart, and found that on consensus indications for these patients, only about 35% underwent endarterectomy for appropriate reasons, and that overall there was a 10% risk of perioperative stroke or death in the 1,300 patients he evaluated. So it was this study that Dr. Winslow published that then really kind of became the impetus for these future trials in carotid stenosis. The first being the NASCET trial, so the North American Symptomatic Endarterectomy Trial. As I'm sure many of you have heard this before, they enrolled about 660 patients, and these patients had to have symptomatic carotid stenosis with greater than 70%. And they had to have some flow, so that's why they listed at 99%. So there's, they had to have even just what they call a string sign through the lesion. They were randomized again to best medical management versus best medical management and endarterectomy. And what they found here was that there truly was a benefit for endarterectomy for these patients. So there was an absolute risk reduction of about 17% in total, and then a 10% risk reduction for a major or fatal ipsilateral stroke in the 2 years following endarterectomy. So this really kind of set the bar and said, hey, listen, for patients who have symptomatic carotid stenosis that is greater than 70%, that intervention really does benefit them. So then the question is kind of began, what happens for those patients who are asymptomatic, right? Meaning that they are found to have carotid stenosis, but they don't have, they never had a TIA, or they haven't had any type of ipsilateral stroke in that area. So the asymptomatic carotid atherosclerosis study, or ACAS, which was published in 1995, had even more patients, nearly 1,700 patients enrolled. The inclusion criteria had to be that they had asymptomatic carotid stenosis, but that were greater than or equal to 60%. And again, they were randomized to best medical management and versus best medical management plus endarterectomy. And what they found here is that the risk of ipsilateral stroke and endarterectomy was really halved almost within the 5-year period following endarterectomy. But the caveat for this trial was that they had a really low perioperative morbidity and mortality for these patients. So they really kind of put an asterisk at the end of their results and said, listen, our perioperative major morbidity and mortality was about 3%. So these patients really only benefit truly if you can keep your morbidity, lower than that. So otherwise, the risk reduction becomes, more and more minimal. So the next kind of trial that I think people also discuss is the European Carotid Surgery Trial, or the ECST. So this, again, you look at these numbers; these are pretty large numbers. About 3,000 patients were enrolled. Their inclusion criteria was much more broad than these prior studies. So they basically said any degree of symptomatic carotid stenosis, no matter what, we'll look at, we'll enroll them in the trial and randomize them. So they were then randomized to best medical management versus endarterectomy. And what they found more than anything, I think the takeaway point or conclusion from this trial was that those patients with very high grade stenosis, meaning greater than 80%, again, had a large absolute risk reduction of an ipsilateral stroke or death of about 11% at 3 years. So again, the ECST really kind of confirmed the findings of NACIT that these patients with symptomatic high-grade stenosis truly benefited from any type of intervention rather than just medical management alone. And then the asymptomatic carotid surgery trial, the ACST, which was published in 2004, again, about 3,000 patients were enrolled. And this was, again, looking at asymptomatic carotid stenosis. So, the question again was, truly who does benefit, if they have asymptomatic carotid stenosis. And again, they had to be greater than 60% stenosis, and they were randomized to best medical management versus endarterectomy. And again, what they found here, similar to the previous ACAS study, was that if you really can keep your perioperative morbidity low for these patients, that they really do have a decreased ipsilateral stroke risk if they undergo endarterectomy. So all these previous trials here were all really just discussing surgical intervention for endarterectomy. And that's really because, as you can see here on this little, timeline, that carotid artery stenting really didn't come around until the early 90s. So Dr. Dietrich, who was a cardiovascular surgeon, he was really the first to describe carotid artery stenting as an alternative for endarterectomy. But even he, at that point, found that perioperative stroke and TIA risk was way too high to recommend widespread use of it. He quoted about 10% for a carotid artery stent. So it really wasn't until Dr. Yadav and Parodi developed the first, what we call proximal protection procedure, which is that they basically developed a device in which they could reverse the flow in the carotid artery so that you would have retrograde arterial flow rather than anterograde intracranially. When they developed that, and then further tested some distal embolic protection devices, which were small devices that look kind of like a net that would stay distal to the plaque and potentially catch any emboli that would go intracranially. These were the ones who really found that they could decrease the procedural stroke and TIA risk with carotid stenting. And so that really wasn't even until 1999 or 2000. And then also, I'd be remiss if I didn't talk about the TCAR procedure, which is a newer procedure that's kind of a hybrid between carotid endarterectomy and carotid stenting. And Dr. Criado and Chang were the vascular surgeons who developed this technique in 2012, and we'll kind of describe it a little bit more later on. So In 2001, the Cavitas Trial, which is the carotid and vertebral artery transluminal angioplasty study, is kind of the first bigger study evaluating endovascular treatment versus endarterectomy. They enrolled about 500 patients, and again, they had kind of broad inclusion criteria. So they didn't have to be symptomatic or asymptomatic. It was anyone with carotid stenosis or carotid plaque that believed needed treatment by the physician evaluating the patient. So anyone who had a lesion that the physician felt needed treatment could be enrolled in the trial. They were randomized to either carotid stenting or endarterectomy. And interestingly, here's what they found is that, the 3-year outcomes for stroke, ipsilateral stroke or death were about similar in the carotid stenting versus endarterectomy arms of the trial. And interestingly, they also found that the main difference was that the endovascular treatments had less access site complications than endarterectomy. So that kind of set the tone for some of these other trials. The next one is the Sapphire Trial in 2004. This is stenting and angioplasty with protection in patients at high risk for endarterectomy. So again, a lower number than the prior endarterectomy trials. So you can see that this is 330 patients about. So it's real, almost an order of 10 smaller than the prior trials. But the reason is because I think, the inclusion criteria for this trial was much more stringent. They were really looking at either symptomatic carotid stenosis greater than 50% or asymptomatic greater than 80%. And these patients had to have comorbidities that made them at increased risk of endarterectomy. So patients who had, concurrent cardiovascular disease or pulmonary disease. So they were randomized to either carotid artery stenting with embolic protection or endarterectomy. And what they found is that, again, kind of mimicking the prior Cavitas trial, was that at 1 year, carotid artery stenting, really wasn't much different in terms of stroke and death than carotid endarterectomy, and that they did find that there was a lower risk of periprocedural MI. So this was the first trial that really established the indication for carotid stenting in patients at high risk for surgery. And it set the tone for the CREST trial, which is the one that I think everybody is most familiar with. So I think the most important thing that sets, the CREST trial apart than the prior trials evaluating endovascular treatment of carotid stenosis was that they enrolled 2,500 patients. So they had a large sample size to evaluate, and they included patients who were symptomatic carotid stenosis greater than 50% or asymptomatic carotid stenosis greater than 60% on angiogram. They were again randomized to either carotid artery stenting or endarterectomy. And what they found, interestingly, and this is the kind of thing that Dr. Hiros would talk about all the time at conferences, that they looked at composite outcomes. So there was no difference in composite outcomes of stroke, death, or MI. When you added them all together, comparing stenting to endarterectomy at 4 years. However, if you looked at individually these primary endpoints of the trial, they found that those patients with endarterectomy had higher risk of MI, and those patients with carotid stenting had higher risk of stroke. Now, some of the criticisms of this trial was that they included a troponin leak under the MI complication or primary endpoint. So that's kind of the argument that Dr. Hiros makes, is that, if you're someone who is, kind of at clinical equipoise between carotid artery stenting or carotid endarterectomy, would you rather have a perioperative MI leak or a perioperative stroke? Perioperative troponin leak or a perioperative stroke? And I think most people, would probably take an asymptomatic troponin leak over a perioperative stroke. And furthermore, when they looked at patients, who were older, those patients benefited more from endarterectomy. And I think, the reason here that is not as intuitive if you're not someone who hasn't done any endovascular work, is that, the patients who get endarterectomy, you have direct access to their carotid artery. For a carotid artery stent, you're introducing a large bore catheter system through their peripheral arterial arteries and their aortic arch, which, if they have, stenosis or atherosclerotic plaque in their carotid, they're likely to have it elsewhere. So this large, relatively non-flexible system is being pushed from their femoral artery all the way to their carotid artery. And there's, potential risk for, dislodging a plaque within the aortic arch and causing an embolus prior to even having an embolic protection device, distal to the plaque. So this is kind of the reason why I think older patients fare better with endarterectomy, is because they're at, they have inherently more tortuous vessels and likely have more atherosclerotic plaque elsewhere, and thus we're at higher risk for ipsilateral stroke. And then that kind of brings us to the next trial, which I think is important and relatively new, is the Roadster trial, or the reverse flow used during carotid artery stenting. This was the trial to evaluate the TCAR procedure that we were describing previously. So again, low enrollment, they had only 140 patients. They were looking at symptomatic carotid stenosis greater than 50% and asymptomatic greater than 70% in patients who were poor candidates for endarterectomy. And what they did was it was a single arm study. So they really just enrolled patients who they thought would benefit from stenting. And then they performed the TCAR procedure. And what they found was that their 30-day stroke death in MI was about 3.5%. And their overall, when you broke it down into stroke alone, it was 1.4%. So this was kind of the lowest, 30-day stroke, perioperative stroke risk for any carotid stenting trial overall. And the reason why this happens is because, just like we described, this is kind of a diagram of how the TCAR procedure is performed. So it is a stenting procedure, but what they do is that they actually do a cut down on the carotid artery. So it's a small incision in the neck, and then they introduce a sheath directly into the common carotid artery. They then put that on reverse flow. So it has a proximal protection device so that the flow is reversed within the carotid artery to prevent any distal emboli going intracranially. And then that blood is then reintroduced through a femoral sheath into a femoral vein. And then they perform a carotid stenting procedure, as you can see here, kind of across the plaque during this reverse flow state. So I think in general, this kind of bypasses the risk of putting a large bore catheter system through the peripheral arteries or the aortic arch and potentially dislodging a plaque before you ever even get to the carotid. So this is, I think, why the stroke risk was decreased, comparatively. And then lastly, most recently, even last year, the ACS2, or ACST2, which was the second iteration of the asymptomatic carotid surgery trial, looked at 3,600 patients. So again, a large patient population, all had to be asymptomatic and all had to have greater than 60% stenosis. They were randomized to endarterectomy versus stenting. And again, they found what other studies kind of showed is that at 5-year follow-up, there's about no statistical significant difference in ipsilateral stroke for carotid artery stenting or endarterectomy, although it was a little higher with stenting, which again makes sense based on what we kind of already talked about. So that being said, as I told you, at the beginning of the talk, my clinical interests have been leveraging big data to see how these trials have really affected practice patterns. So, looking at, a large, inpatient database, we evaluated kind of over time what's been happening to these different procedures since, these trials have all come about. And what we see here is that there's been a statistically significant decrease in carotid endarterectomy procedures performed with a corresponding increase in carotid artery stenting. Interestingly, the TCAR procedure, although has been increasing, hasn't dramatically taken off in the last 5 to 6 years, despite it showing that the results were pretty good. And then what we see here is that when we're evaluating the perioperative period, as you would expect, we tend to see that carotid artery stenting tends to have more major adverse events than either endarterectomy or TCAR. And again, I think that's mostly because of perioperative stroke, because of carotid artery stenting has a higher risk of stroke, and we all know that. And then this is just a comparison of TCAR looking at endarterectomy and stenting. So you can see here that TCAR really remains comparable to endarterectomy and stenting in regards to perioperative complications, but again, just has not gotten much traction in the endovascular community. And I think mainly because it's a learning curve, and because there are many neurointerventionalists who probably aren't surgeons, and it requires a understanding of neck anatomy, at least an incision in the neck, in order to gain access to the carotid artery. So, that's a lot of information regarding carotid stenosis. I think, I put this slide in here just because there's a ton of trials in carotid stenosis. And I wanted to give you kind of the salient points, and synthesis of all of those trials. And what we really found more than anything is that those patients with symptomatic carotid stenosis, so at least 50 to 70% with a history of an ipsilateral stroke or TIA, they definitely have decreased stroke and death after intervention, meaning that, these people truly do benefit from an intervention. And what we found even further is that those patients with higher grade stenosis, meaning even higher than 50 to 70%, seem to have even further risk reduction with intervention. Those asymptomatic patients really have to have greater than 60% stenosis, and they may fare better with intervention, is what all of our asymptomatic trials seem to suggest. But the most important thing here is that patient selection is important, and reduction of your perioperative risk, because as the perioperative risk increases, the benefit really decreases with these asymptomatic patients. And then, overall, endarterectomy and carotid artery stenting appear to have relatively similar outcomes when it comes to overall outcomes, but carotid artery stenting really has higher periprocedural stroke risk in the majority of trials, even if it remained non-significant. And then new technologies such as TCAR are really further reducing this risk of periprocedural stroke, so that stenting has become even less risky. But the truth is just as many of you know, there's really a nuanced decision making about patients' anatomy, their age, their comorbidities, in order to decide whether or not they're really a better candidate for endarterectomy versus stenting. So we're going to kind of shift gears a little bit. We're going to continue to talk about atherosclerotic disease, but now we're talking about intracranial atherosclerotic disease, or ICAD. Many of you probably don't have a ton of experience with this if you haven't done endovascular, if you're not interested in endovascular, and that's because, as we stated previously, those prior trials looking at bypassing these lesions really did not show any benefit. So it's something that has really been the cross to bear for many of the endovascular people. And this is why, there's many times, that we have these patients who show up with a proximal M1 occlusion. You do a thrombectomy, you open them up, and then their angiogram looks like this, and they have this stenotic lesion. The flow is still decreased through it, when you inject the carotid. And then you wait 5-10 minutes and the artery shuts down again because there's some, plaque there that's just causing a thrombus to form. And the question is what to do with these patients. Many times, the answer is you have to end up stenting them anyways. But, the really large trial that evaluated the endovascular intervention for these patients was this trial called the Sampers Trial. And it was stenting versus aggressive medical therapy for these patients with intracranial atherosclerosis. And what they found was that 450 patients were enrolled, so relatively small, but again, this is a relatively rare disease state compared to carotid stenosis. And they had to have symptomatic intracranial stenosis greater than 70%. So that means they had to have either an ipsilateral stroke or persistent symptoms in that ipsilateral hemisphere. They were randomized to best medical management versus best medical management and angioplasty and stenting. And what they found in this trial is that enrollment stopped after about a year because 30-day stroke and death was found to be significantly higher in the intervention group. And just so you understand the breakdown, the majority of these patients had either MCA stenosis or basilar stenosis, with the remainder, I think it's about 15 or 20%, making up ICA and vertebral artery stenosis. So really what we found here is that intervention is not, can be hurtful to these patients. But it's still hard to make that decision when, they have a large vessel occlusion and it keeps shutting down. So I think the jury is ultimately still out there. From an endovascular standpoint, we rarely treat these unless they're really failing maximum medical management, meaning that they're getting everything that they can and they're continuing to have ipsilateral hemispheric symptoms. So that kind of, discussion brings me to the next topic, which is acute ischemic stroke. As I'm sure many of you have heard, at least peripherally, kind of the evolution of this treatment. But I kind of wanted to start just to give you a little historic background. 1983 was really the first report of using intraarterial thrombolysis or basilar occlusion. And they found that when they did this, there was, 60% of the patients, so they only had 5 patients, but they had 3 of them had recanalization of their basilar artery with some clinical improvement. So the next iteration of that was that in 1992, they began doing what they called angiography-based dose escalation of IV TPA. So they actually parked a catheter in these patients and delivered IV TPA, and then did serial injections of their carotid to see if the occlusions improved. And what they found was that if these patients had distal M3 occlusions, those often recanalized with IV TPA, but the recanalization rates remained low for more proximal vessel occlusions like an M1 or an M2. So in 1995, this was the first time a trial demonstrated that IV TPA improved clinical outcomes within 3 hours of symptom onset for stroke. So, you think about it, that was within my lifetime that IV TPA was developed. In 1996, FDA approved IV TPA. And as people really wanted to expand the window for treatment, right? I mean, there's a lot of patients who still woke up what they call, they have wake up strokes, meaning that they woke up, went to bed normal and woke up and they had a stroke in the middle of the night and no one knows really the timing. So these patients weren't IV TPA candidates. Then this kind of prompted the endovascular therapy, right? Because they said, well, if we're going up there and we're injecting intra-arterial thrombolysis, then maybe we can do something different. So, there was a number of negative thrombectomy trials. The PROACT trial used intra-arterial pro-urokinase for MCA occlusions within 6 hours of symptom onset. And they found even then that they had high rates of recanalization, even though those patients who were outside the IV TPA window. The PROACT 2 trial showed improved clinical outcomes and increased rates of M1 recanalization with IV thrombolysis. But again, they had a relatively small sample size and there was really marginal significance. So that didn't become standard of care when they were, when patients were already receiving IV TPA anyways. So then, what they did really do is change the world of ischemic stroke because it gave these companies the incentive now to design devices for thrombectomy, meaning that they said, okay, if they're parking these little catheters up there and they're injecting, a thrombolytic agent, why can't we just develop a device that's going to remove this clot? So then we saw the TIME trial, the MERCY trial, the Ecst 3 trial. All of these trials were using a variety of different technologies to try to remove these clots. The TIME trial used aspiration alone. The results were negative, never published. The MERCY trial used a Stent Retriever and had about a 48% recanalization rate, but they had a really high mortality rate with about 42%. And then the Ecst 3 trial showed better 90-day outcomes with IV TPA. So, these patients, the Ecst 3 trial showed that IV TPA worked even better, even outside of the 3-hour window up to 4.5 hours. So in 2008, they expanded the IV TPA to about 4.5 hours. So, these trials for thrombectomy with devices were being, performed when they were even showing that IV TPA worked even, in a longer period. So, then even in 2013, we had these 3 trials that showed no benefit from thrombectomy compared to IV TPA alone. So mechanical thrombectomy, meaning using one of these devices, whether it was aspiration or a stent retriever to remove these clots. So, there was all these failed trials, and IV TPA seemed to be the only thing that really worked for these patients. And even then the results weren't great. And then along came MR Clean. So I'm sure this is the trial that everybody has heard about. This was the first mechanical thrombectomy trial to demonstrate any true benefit from mechanical thrombectomy versus IV TPA. The prior 3 trials that we talked about were likely negative for multiple reasons, but mostly poor trial design and technology. The IMS-3, which was one of the largest trials, used an NIH stroke scale as their threshold rather than a CTA that confirmed an LVO. So what they found is that there was 8% of the patients that were enrolled that got randomized to intervention had open vessels on angiography. So, obviously you can tell that that's going to totally skew the results. So why was MR clean the one that was that showed true benefit? I think it's because they really honed in on not only who they enrolled, so they had to have a confirmed LVO in the anterior circulation, but they also refined how they were going to do the thrombectomy. They really said, if you're going to enroll these patients, they have to be done in a certain way, and you have to use this stent retriever. So stent retrievers were initially designed as a stent scaffold for coiling of aneurysms. So if you can imagine, what they would do is deploy this device that really sat around the parent artery, and then they would coil the aneurysm through the device, and then they would remove the coiling catheter and then remove the stent, and then the aneurysm would be coiled. So it was a way of doing a stent-assisted coiling without leaving a stent within the parent artery, so that they didn't have to be on dual antiplatelets. So they kind of asked themselves, hey, well, the predecessor that was used in Mercy, why can't we make another iteration of that and use it in this? And that's what they did. And so this was, what they found was that patients within 6 hours of symptom onset with an anterior circulation, large vessel occlusion, really had improved clinical outcomes at 90 days compared to IVTPA alone. And I like to think that this trial, it was really the Pandora's box for endovascular treatment of acute ischemic stroke, because everything after this has now become more and more positive for intervention, and techniques have changed and improved. So several years later, in 2018, the Dawn and Diffuse trial came out, and this, I think Stephanie, can attest to this. These results kind of came out right when she was doing her endovascular year, and certainly were pertinent to me when I did my endovascular year. Is that they basically found that mechanical thrombectomy still improved 90-day clinical outcomes in patients with an anterior LVO who had up to 24 hours of symptom onset, as long as they had what we call a perfusion mismatch, meaning that they had, even if they had an ischemic core, meaning that there was an area of ischemia that was dead brain, as long as they had a large area of that hemisphere that still was not dead, but underperfused, that they still benefited from mechanical thrombectomy. And this was huge, because this is kind of now, this includes these patients who have wake-up strokes, right? The patients who go to sleep normal and wake up the next morning, with a stroke, they could be enrolled in this trial and still have potential benefit. And then, this is the one that kind of boggles my mind. It was, I saw it at the stroke conference, the ISC this year in 2022. So the Rescue Japan study was performed in Japan. They enrolled patients with already a large infarct on CT into mechanical thrombectomy versus medical management alone. And they, again, they had to be last known normal within 6 hours, or they had to have what we call no flare signal on MR, meaning that there's no area of increased, dead brain within 24 hours of last known normal. And what they found is that even these patients with large ischemic cores still did better at 90 days compared to the medical group. So, for me, this means that obviously our techniques for mechanical thrombectomy are significantly improving if now these patients with even large ischemic cores are getting reperfused and still doing better. So I think for me in general, this is a huge positive, although it makes us, it's relatively painful because you have to wake up in the middle of the night to do these things sometimes. It's really life or death for these folks. And it shows that there is potential for significant improvement even in these patients who have large areas of ischemia already. So that kind of concludes our discussion about ischemic disease trials. I wanted to kind of now move on to hemorrhagic disease. So we're going to first talk about aneurysms. I think, I'd be remiss if I didn't talk about the Ishua study. I'm sure this has kind of been beaten to you guys over and over and over again. The international study of unruptured intracranial aneurysms. This is really the first good prospective observational study evaluating the natural history of aneurysms. It was in 2003. They only enrolled unruptured, untreated aneurysms in patients who had a Rankin score less than 2, meaning that they were functionally independent. And I think the important thing here is that this was actually a trial in which they randomized patients to observation, open surgery, or endovascular treatment. That doesn't often get talked about, that there was actually people in the Ishua trial that got open surgery and endovascular treatment. Because mainly the most important results was their observational arm. So, what we see here is that, they did find that there were some predictors of poor outcomes for unruptured aneurysms getting surgery. And what they found was that older patients, meaning patients older than 50, who had aneurysms greater than 12 millimeters, who had aneurysms in the posterior circulation, or had a prior ischemic event associated with their aneurysm, or aneurysm symptoms other than rupture, meaning mass effect, seizures. All those patients had poorer outcomes than their counterparts getting surgery. In the endovascular arm, what they found was that there were the only real predictors of poor outcome were large aneurysms greater than 12 millimeters, and posterior circulation location. So again, remember, these are unruptured aneurysms. And I think this is the table that everyone, talks about in the Issue study, because it was really important at that time, because no one truly understood the natural history of aneurysmal rupture. So they took these unruptured aneurysms. There was 1,600 or so patients enrolled in this arm, and they followed them for 5 years. And they looked at, the predictors of hemorrhage. And what they found was that, obviously, you can see it's graded based on aneurysm size, that there was incremental hemorrhage risk based on increased aneurysm size. And then what they found is that patients with posterior circulation or Pecan location aneurysms had higher risk of rupture than other anterior circulation aneurysms. So, that's huge, because then that allows us to really talk to patients about what we think their rupture risk is based on the size and location of their aneurysm. So, there are criticisms with this trial. Obviously, what they mean is that it's non-randomized, in the sense that they had patients that if they felt that they really needed treatment, meaning this, they thought that this aneurysm was, very high risk and couldn't be observed, they treated it. So they didn't truly randomize the patients. There's also some discussion about why Pecan aneurysms were included in the posterior circulation subgroup, because they, obviously, as you guys know, that these aneurysms arise from the internal carotid artery. And then everyone knows that there is some small anterior circulation aneurysms still have non-zero lifetime rupture risk. So you can see back here, right, in this group, that anterior circulation aneurysms, if they were less than 7 millimeters and had no history of subarachnoid hemorrhage, their 5-year rupture risk is 0. Now, that just can't be true, right? That their lifetime rupture risk has to be non-zero, but obviously is relatively low. And I just included this here because, years later in 2013, albeit it was a retrospective study, but they evaluated anterior communicating artery aneurysms and found that those aneurysms that were 4 to 7 millimeters, so they were aneurysms that would have been classified of 0 rupture risk in the Issue study, were found to have similar rupture odds to posterior circulation aneurysms, meaning that they had higher rupture risk than we previously believed. So it's just important, that those are a little nuanced. The next trial is Icesat. I'm sure many of you guys have also heard of this trial before. We talk about it a lot in conference. The International Subarachnoid Aneurysm Trial was in 2002 when it was published. And again, it was a randomized controlled trial of 2,100 patients with ruptured aneurysms. So the important difference between the Issue trial and the Icesat trial is that these patients were ruptured. They had over 1,000 patients randomized to clipping and over 1,000 patients randomized to coiling. And what they found at 1 year was that coiling had significantly better neurologic outcomes, meaning that there were more people who were functionally independent at 1 year. However, there was a non-zero rebleeding risk at 1 year in the coiling group as compared to the clipping, but it was still less than 1%. So this was, this trial really demonstrated that there's, disability-free survival at 1 year was really higher in endovascular treatment compared to clipping. Again, with the caveat that there was long-term rebleeding rates that were low but higher in the coiling group. And so, the main criticisms of the Icesat trial that I think it's important to denote here, and this is what this table shows, is that many aneurysms that did not have what people describe as clinical equipoise between coiling or clipping were excluded from this trial. So, meaning that, at this point in time, many people believe that basilar aneurysms should be coiled, already. So they felt like those patients really shouldn't be enrolled in terms of, randomization to clipping or coiling. And then again, also MCA aneurysms, many people felt that those should still be treated with clipping. And so they didn't really feel that there was clinical equipoise enough to enroll them. So you can see here in this table, what ended up happening is that the majority, over 80% of the patients in the Icesat trial were either anterior cerebral artery or internal carotid artery aneurysms. So meaning that they were basically ACOMs or internal carotid artery. So the point being is that, when you look at the results of the Icesat trial, you have to understand that it really was an evaluation of ACOM aneurysms and internal carotid artery aneurysms more so than MCA or basilar. So that being said, again, we kind of looked at, our results, over time about what has happened in the Icesat, following the Icesat trial. And this is an evaluation here of all comers, all aneurysms being treated in the United States. And we found that endovascular therapy has dramatically increased in the 10-year period following Icesat, while clipping has, mildly decreased or about remained the same. When we break that down into patients who have ruptured aneurysms, you can clearly see that early on, ruptured aneurysms, there was still an inclination for most people to treat with clipping versus coiling. And then that kind of transitioned to the opposite. So that ruptured aneurysms now in 2014, had higher risk or higher rates of coiling versus clipping. And then when you're looking at unruptured aneurysms, the clipping rates remained about stable, while coiling increased dramatically. So the overall kind of take-home point from our results is that treatment trends, in these aneurysms in the post-Icesat era have really shown that there's an increasing proportion of patients with aneurysms being treated with endovascular occlusion, while rates of aneurysmal subarachnoid hemorrhage have really, clipping have really decreased. So, I think it's important to talk about these other endovascular trials that don't get as much attention during our morning conferences because they're very important. As any of our residents here have dealt with patients who, have had a pipeline and what that means. So this is kind of the trials that really, decidedly said that pipeline or flow diverting stent intervention is of benefit to these patients. So the PUFS trial, it's the pipeline for uncoilable or failed aneurysms, had 108 patients with unruptured but large or giant wide-necked aneurysms that had also potentially failed other treatments. The mean aneurysm size was about 18 millimeters, and at 20% of these patients, so 22 of the aneurysms were considered giant, meaning greater than 2.5 centimeters. What they found here is that from the pipeline intervention that at 6 months, 73% of the patients had complete aneurysm occlusion without in-stent stenosis. They had about a 5%, peri-procedural risk of major ipsilateral stroke or neurologic deficit. So this really showed that flow diverting stents. This was the first time that we saw that flow diverting stents had a reasonably safe and effective ability to treat these large or giant internal carotid artery aneurysms. So and demonstrated high rates of aneurysm occlusion with low rates of neurologic events, even in these aneurysms that had failed previous treatments. So, that was for giant aneurysms, but as I'm sure many of you know, we also do pipelines for smaller aneurysms that are smaller than 18 millimeters. So, the premier data here, which is the prospective study of embolization of intracranial aneurysms with the pipeline device, was published in 2019, and then the 3-year follow-up was published in 2021. Again, there were 140 patients enrolled. The mean aneurysm size here was 5 millimeters, so much smaller, and 84% measured less than 7 millimeters. So again, small, wide-necked aneurysms. What they found was that at 1 year, about 75% had complete occlusion with no in-stent stenosis, and 83% had the same outcome at 3 years. Here they had a 2.1% major ipsilateral stroke or neurologic death. So pretty low perioperative complications for this treatment. And this was the first trial that really showed that the treatment of wide-necked, small to medium-sized aneurysms with the pipeline or a flow-diverting stent really had high rates of complete occlusion without parent vessel stenosis and low rates of complications. So as you can see, this kind of is why, people, pipeline seems relatively favorable. The procedure itself is about, 45 minutes to an hour. You can do it radially now so that people can be up and walking around. And the treatment for these aneurysms, it has relatively high occlusion rates with relatively low risk. So, I kind of wanted to finish the talk with AVMs because I think, as everyone knows, the big trial associated with AVMs is the Aruba trial. There's lots of controversy surrounding it, and I kind of want to give it some time because I think it's important to discuss because, as many of you know, in our department especially, we continue to treat AVMs because we think it's the right thing to do, and I'll go into that why that's the case. The Aruba trial, the results were initially published in 2013. There was about 220 patients with unruptured AVMs that were enrolled. There were 114 enrolled to intervention and 109 enrolled to observation. The important distinction here is that the interventional arm included any treatment deemed appropriate by the local Aruba investigator to achieve complete obliteration. That doesn't mean that they had to achieve complete obliteration. It just means that the physician enrolling the patient thought that the treatment may lead to complete obliteration. So what they found in 2013 was that Aruba prematurely halted because an interim analysis found that medical therapy alone, meaning the observation group, resulted in less death and symptomatic stroke than the interventional therapy for these patients. At this point, average follow-up was less than 3 years, so 2.75 years. In 2020, the final Aruba analysis continued to demonstrate better outcomes with the medical management alone. And at that point, the follow-up was about 4 years. So I think the important takeaway here from this is that, this is from Aruba itself, the patients that were in the interventional arm. So you can see here that there were only 5 patients within the interventional therapy that got surgery alone. 30 of them had embolization alone, and that was not necessarily embolization for cure. That included partial embolization. There was radiotherapy alone, which was 30, which is also, again, a large proportion. And then there was only 12 that had a multimodal approach combining embolization with neurosurgery or radiotherapy. So again, if you look at it, less than 20 patients received surgical resection of their AVM in the Aruba trial. That's less than a fifth of the patients that were enrolled into intervention. So again, I think, ultimately these findings of the trial really challenged the clinical practice of cerebrovascular specialists. It resulted in many critiques, which really served as the impetus for several investigations afterwards. Most of them, albeit, were retrospective. In general, though, these retrospective studies demonstrated better long-term outcomes than the interventional arm of Aruba using identical endpoints. So really what this suggested is that, these people thought that the outcome discrepancy between their cohort and that of Aruba was really due to their careful patient selection and their increased use of surgery as a primary therapy. So furthermore, the important thing to note here is that the trial was initially designed with a follow-up period of 12 years. So the question is early cessation at less than 3 years of follow-up, is that really enough to truly compare upfront treatment risk to the lifetime rupture risk of AVMs? So again, looking at our data, what we kind of wanted to see was that, is there an effect that Aruba has had on interventions for both ruptured and unruptured AVMs in the years before and after Aruba? And what we found is that in the 4-year period before and after Aruba, for ruptured AVMs, there was really no change in interventions, but there was a change in the type of interventions with decreased surgery being performed and increased embolization being performed. Then when we looked at unruptured AVMs, what we found was that there was a significant overall decrease in any intervention following Aruba. So then this kind of begs the question, okay, compare, what happens then and when did it really change? When did that change in intervention occur? So, we used, kind of simple linear regression. We saw that there was a steady decline in treatments over the 8-year period between the 4 years before Aruba and after Aruba. But when we used segmented linear regression, what we found was that there was a really significant change point in the period, the peri-Aruba period, meaning 2014, 2015, it was already declining, but there was a significant sharp decline following Aruba. So we then wanted to see if this decline, in interventions had really any effect on rupture incidence. And this is what we found, that although ruptured AVM treatments didn't change, there was a significant increase in rupture incidence in the post-Aruba period. So we then kind of expanded our analysis to even further back to really understand what was happening. What we did was a look back all the way to 2003, and this is what we found. In segmented linear regression, there was a significant change point for ruptured AVM incidence in 2011. And in 2017, the annual rupture incidence surpassed the annual intervention rate for the first time. So I think what does this mean? Ultimately what it means for us is that there was a correlation between annual intervention rates and annual rupture incidence, and they had an inverse correlation with one another. Both correlated with time and forming a relationship that we would expect in a cumulative risk model. So in general, the idea is, theoretically speaking, if we perfectly intervened on every existing AVM, then AVM rupture incidence would be 0. However, inversely, if we never intervened on any AVM, then rupture incidence would then plateau at some unknown level. What we found here is that it appears that there's an 8-year lag between a declining intervention and then a change in rupture incidence. So meaning that every unruptured AVM that would have been treated at an earlier time point accumulates rupture risk as time passes. Therefore, the immediate effect of a single decrease in intervention would not be fully reflected in that same year's rupture incidence. Instead, what we will likely see is an increased incidence spread between several subsequent years. So our data here kind of suggests that it requires potentially up to 8 years to observe a change in rupture incidence. As such, it suggests to me that the follow-up period, even at final analysis of Aruba, was probably not long enough for us to truly capture the natural history of these AVMs. So, again, that kind of comes to the end. My conclusions is that, like, from the very beginning, we've come a really long way. We have way better technologies. We have way better experience. But there's certainly more to do. And I think, for the resident standpoint, it's our job to do it. If you have a question or an answer, or you think there's a better way, it's your job to be the spearhead for that. So thank you guys for letting me talk this morning. I appreciate it. And if you have any questions, feel free to let me know. Yeah, I'm happy also to send this PowerPoint out to anybody who wants it.